So I wanted to start off by welcoming everyone to our case conference. I'm Tua Pal. I'm based at the Vanderbilt Ingram Cancer Center, and myself and my colleague Brenda Zuniga will be moderating this case conference. So I wanted to give a big shout out to our guest experts, who will be Dr. Marc Tischkowitz in the UK and Dr. Stephen Narod at Women's College Hospital in Toronto. So I wanted to give a little bit of a background about the Inherited Cancer Registry. And the whole, this was started about 10 years ago. We have over 4,000 participants consented, including over 1,300 BRCA carriers and over 1,000 individuals with other inherited gene mutations. And the way we've done it is we have partnered with providers across the country and beyond. Many of you have partnered with us, for which we're thankful. And we have provided both patient and provider resources, including educational resources. That in turn has led to growth of our registry and again, enabled us to increased our ability to do translational studies. So the resources that are available through ICARE include our monthly case conferences, which are these, and we do them once a month on Thursdays from 11:30 to 12:30 Central Time. We also put out biannual newsletters where we outline important advances in inherited cancer clinical and research content. We have a website through which we have a lot of information available, and then we put out information through social media as well. Now, in terms of referring to ICARE, it's super easy. Providers who are interested in partnering with us can refer through our website, or we can provide prepaid postcards. We're the ones who do all the work with consenting. Just wanted to mention there are many recruitment sites. I think over 200 providers have referred to our registry. We have many sites that recruit to ICARE, as well as many sites that attend these case conferences. So with these recruitment efforts, we have a breast cancer treatment study evaluating treatments among women with PALB2 and breast cancer. This is an effort led by my colleague in Toronto, Dr. Kelly Metcalf, alongside Stephen Narod and myself. The purpose is to identify and follow 500 women with breast cancer and a PALB2 mutation, and really to look at survival and predictors of survival as well as treatment. And we've enrolled about 300 PALB2 carriers, many of whom have been recruited to Kelly's study. And you can see here the overall growth of ICARE over the years, over the last 10 years, as well as the PALB2 carrier growth. Really, we started this around 2014, 2015. Again, you can see how that effort has grown. So I wanted to start off with a case to kind of set the stage for both Dr. Tischkowitz's and Dr. Narod's talks. So here's the patient history. This is a patient I saw a few weeks ago. And the reason for referral was he was a 60-year-old with elevated PSA seen in our urology clinic. He also had a familial PALB2 mutation and a family history of triple-negative breast cancer and aggressive prostate cancer. So the history is in December of 2020, he was referred to urology for an elevated PSA to 3.67 compared to 2.29 in 2018. And our urologist at Vanderbilt referred him to our service for counseling and testing. Now, he had a brother who was deceased with metastatic prostate cancer and had had a PALB2 mutation detected. He had another brother with prostate cancer whose status post-prostatectomy, and a sister with triple-negative breast cancer. His results were that he had a PALB2 mutation, and in April of 2021, he had a prostate biopsy, which identified cancer. So it was Gleason 6, grade group 1. So here we have the pedigree. So you see the proband is here. 60-year-old with what's classified as low-risk prostate cancer. You see here's the brother who'd had prostate cancer in his 50s, which initially was classified as low risk, But then it came back, and he had been initially treated with watchful waiting. It subsequently metastasized, and he died at age 58. He's the one with the PALB2 mutation, which was originally diagnosed in him. There is another brother, age 60, with prostate cancer who had a prostatectomy. I don't know the Gleason. He's currently 69, has not been tested. There's a sister here with triple negative breast cancer, who was diagnosed at age 50, currently 63. And then in the upper generation, there was a father who had stomach cancer at 85, died at age 86. There's no pathology records though, so we don't know exactly what kind of cancer it really was. So in terms of medical management, the patient was treated, had various options for treatment for his prostate cancer. So the urologist had a very lengthy discussion about active surveillance versus surgery versus radiation therapy. And he's also been referred to one of our radiation oncologists at Vanderbilt as well. What they're planning is to send for Oncotype DX testing, which, again, may guide care, but again, we're waiting for those results. There's also a plan to repeat the prostate biopsy at the end of this month. And the patient is very interested in pancreatic cancer screening. He doesn't technically meet the CAPS or NCCN guidelines, but he has chosen to move forward with screening. So we're exploring that as well. Now, with implications for relatives, we have multiple family members here that have chosen not to be tested at this point. And then additional considerations, again, I had reached out to both Dr. Tischkowitz and Dr. Narod about this case. As it turns out, the patient was very concerned given that his deceased brother with metastatic prostate cancer and PALB2 was initially diagnosed with low-risk disease. And he is actually the one that showed me the paper which Dr. Narod published alongside the Polish team, which had just come out that day. And again, Dr. Narod will be telling you more about that paper. And again, the additional considerations here is, to me, how do we take family history of aggressive prostate cancer into account to potentially guide treatment? So with that, I wanted to hand off to Dr. Marc Tischkowitz. And I don't think he needs much of an introduction. When we think of PALB2, we think of Marc. And just to give you some background about Marc, he's a university reader and honorary consultant in the Department of Medical Genetics at Cambridge. He had been at McGill for several years, and he's led many of the efforts with PALB2 worldwide over the more than the past decade. So again, I'm going to hand off to you, Marc, to take it on over.
Thank you very much, Tia, for inviting me to give an update on the PALB2 with a focus on the ACMG guidelines that have just been published earlier last month. So we will kick off. I haven't got too many slides, but it's really an update for the audience to give a flavour of where we are at with PALB2 now. And I do encourage everyone to download this. You've got the link there to read it for themselves, because it is the definitive statement on management right now. So so we got together a group of experts from a variety of different specialities, and importantly from different countries as well, to form a committee, an expert panel to take this clinical practice resource forward. And it was primarily led by Tuya, Doug, and myself, and with the added help of those other members you can see there. And one of the key things was that we did really want to make this truly international. So you can see that that there are 4 members from the US, but actually the majority of the panel were from other countries throughout the world. And I think that was really important, so that we can really try and make this as international as possible. And so there are some pros and some cons to doing this type of thing. So firstly, I said truly international. That's very good. The downside of that is that some of us had to do lots of Zoom meetings at unsociable hours, and particularly Joanne from Singapore had a 5 a.m. start, so that was pretty tough. And if you're doing this sort of type of international consensus, you will get very different perspectives because the people will come from different healthcare systems as well. So there's some, there is definitely, one has to be flexible in terms of what the management guidelines should be within the healthcare system of a country. One has to be pragmatic, essentially. The ACMG process, it was my first experience of it. I found it very rigorous, also quite rigid. So that's the downside of it. But luckily, Doug Stewart, who's very well, has a lot of experience with this, was able to guide us through this. And without his help, I think it would have been very difficult. I think it's a big advantage to have it badged to the ACMG. And we also were given a clear timeline to work to, so that kept the pressure on, which I think is helpful in these things. And it also made it well publicized through the ACMG publication resources that they have in terms of publicity. The other issues that we had were that we were really working with very limited data in some aspects of PALB2 care. And by necessity, there were some compromises and some fudging. So I've got a little fudge score for the next few slides. So 1 is not too bad and 3 is a lot of fudging going on. Okay, so here the main statements from this paper, and again, I do encourage you to read it. So the first thing that we spent some time in discussion, it was an interesting discussion, was really the concept of high and moderate risk genes is really falling by the wayside. And I think this is exemplified by this particular graph from a recent paper where PRS scores were added into penetrance estimates. And you can see how PALB2 really does straddle both high risk and moderate risk. I mean, this is the perfect example of a gene that is neither one nor the other. But you can see that, you will get some BRCA2 gene carriers, a tiny minority that, will have a lower risk, but you'll also get a small minority of ATM and CHAC2 carriers that have a much higher risk as well. So even though, PALB2 is perhaps the best example, this does also apply to the other key breast cancer genes. So coming on to, so that was one of the main things that we said in the paper, we have to get away from this idea of high and moderate. And I think we all will be as PRS testing becomes more commonplace. This is definitely going to happen. On the back of that, we also said personalized risk estimates should be used in guiding clinical management because the PALB2 risk is heavily influenced by family history in particular, and some of the other risk factors that we all know about. So where possible, that should be done. There was good consensus that PALB2 patients should be offered a similar surveillance to BRCA1/2. Again, it can be modified somewhat according to individual risk. And this also includes risk-reducing mastectomy, which again, if you do a personalized risk assessment, you will give the woman a reasonably a good feel for where her risk lies in the spectrum of PALB2 risk. So here, high fudge factor. This was the hardest thing actually. Contralateral breast cancer risk in PALB2, and the problem is here that we don't have good data, and we have published two large or large-ish papers looking at providing risk estimates, but these are all based on retrospective data, and you can't use that to calculate a reasonable estimate for prospective data. So this is a difficult issue, and initiatives like the ICARE initiative, where there will be prospective follow-up, that's why those are so important, because that is where we will then be able to answer these questions. So we've left this very open at the moment, and hopefully people will get reassurance from the fact that the experts were being quite vague on this, and I think you have to then have this shared decision-making approach really with a woman in front of you. Ovary, also difficult, not quite as difficult. We made it clear that ovarian cancer surveillance, so ultrasound and CA125, should not be offered, and this was before the recent paper came out in the Lancet, which quite clearly showed in terms of long-term follow-up that these are not effective in surveillance in women at increased risk of ovarian cancer. And we entertained the recommendation regarding risk-reducing bilateral supplemental oophorectomy, where we said that actually, this could be offered as a shared decision-making process. In reality, the risk under 50 in PALB2 is low. So this could really be offered in a post-menopausal situation, and then you get around some of the other long-term complications relating to premature menopause. So that was, we had some consensus on that based on fairly, small amounts of data. And there are really two studies. One was the paper that was published on the familial risks, which came up with a lifetime risk of about 5%, about 1% up to 50. And then there's a recent case control study, which estimated that risk to be about 3% to a lifetime risk. But you can see the risks aren't high. We definitely know they're not higher than that, because we would have seen more ovarian cancer in these families. But there is an increased risk, and this seems like a reasonable approach. Pancreas, a bit more fudging here, and particularly I think some disagreement in terms of management, and this reflects different positions in the healthcare systems, I think. So, and here we stated this quite categorically. So we said in the US, surveillance of pancreatic cancer is encouraged in the context of a surveillance study, but the position but the door is a bit left open there essentially. But in the UK, one definitely can only do pancreatic surveillance as part of a research study. It's not recommended outside. So, a subtle difference, but nevertheless a difference in how this is approached in two different healthcare systems. There's now emerging evidence, or there's reasonably good evidence that PALB2 carriers do respond well to PARP inhibitors, and which one would expect based on the biology, because the protein is very similar to BRCA2 and it works in the homologous recombination pathway. So this all makes good biological sense. And this is an interesting slide, because you can see here that it doesn't apply to those proteins working outside of that pathway, such as CHEK2 and ATM, but PALB2 clearly shows good response. And luckily, we had some good oncologists as part of the group, and we came to a consensus here saying, given the mechanistic similarities, PALB2 patients may be considered for therapeutic regimens and trials as for those for PALB2. I think this is particularly important because we also saw last week that the Olympia study was finally published with some very exciting and very strong results for BRCA1 and BRCA2, and it does seem. My personal opinion is that should also be applied to PALB2 carriers. Now, I think that it'd be interesting to know how hard it will be to persuade healthcare providers to provide that drug, which is quite an expensive drug, in the PALB2 setting, in the absence of direct evidence, i.e. that PALB2 was not part of this particular study. So I think that's something that's going to go forward, and different healthcare providers may view that differently. Finally, we looked at other aspects of PALB2 as well, and one of them was, what do we do about partners of men or women who carry mutations in PALB2 in terms of the reproductive setting? And we came to the conclusion that we do not recommend routine testing of partners for carrier testing unless it can be justified by the partner's family history of cancer. So I think that's something that does crop up from time to time, and we thought we should address it as well. And so those are really the key points that came out of this, and I would encourage you to read that document in full. It's quite a good read, I think. And we are going to proceed on the back of that. That was well received. We're going to proceed with doing something similar for CHEK2 and ATM coming along. Please also check out the PALB2 website. Tia's already mentioned the ICARE study. We're doing something very similar in the UK, a prospective study called Embrace, where we will, and hopefully at some point we'll be able to combine the data with the ICARE study and have a larger cohort for prospective analysis and really answer some of those questions that we do get asked all the time, such as the contralateral breast cancer risk. And on that, I'd like to finish, and thank you very much.
Thank you, Mark. What we'll plan to do is hold the questions till the end. Let's go on with Stephen's talk and then discuss the case. But everyone will have an opportunity to ask questions, because again, I'm sure that is something that many folks may be interested in. So it's my great pleasure to introduce Dr. Stephen Narod, who is professor in the Dalai Lama School of Public Health in the Department of Medicine at the University of Toronto. He's a senior scientist at Women's College Research Institute. He's one of the most cited researchers in the world when it comes to BRCA. He's won many, many prizes. He's world-renowned. And then just another tidbit, Stephen has been my mentor for over 20 years. So it gives me particular pleasure to introduce him today. So Stephen, take it away.
Thanks, Dua. Okay, so yeah, it's a great case. I mean, that's quite a case you came up with. Certainly unusual, but highly demonstrative. So how old was the man, 60?
Yes, he was 60.
But a 60-year-old man with a strong family history of prostate cancer, who has a slightly increasing PSA from 2.9 to 3.7, which is not dramatic, but increased. So he has a biopsy, shows low-grade Gleason 6 prostate cancer, presumably non-metastatic disease, no other cancer history, strong cancer family history of breast cancer, two relatives with prostate cancer, one of whom died, right?
One of them died, so had initially diagnosed with low-risk disease,
yeah,
which then became
I assume he
metastatic.
had great progression, which goes from Gleason 6 to 7 before he was offered treatment. Maybe he was on active surveillance. This raised a ton of good questions. So the first, I mean, I'll just answer the most important one, I think. What I think, the guy needs a radical prostatectomy. The fact that you had a long discussion with him about the options between radiotherapy, active surveillance, and surgery, to me, might have been, it's nice to talk to the patients, but if you ask me, this guy needs a radical prostatectomy. We'll get back to that. So there's a bunch of questions. First, does PALB2 increase the risk of prostate cancer? Second, is a family history of prostate cancer in the independent risk factor for prostate cancer in a man who has a PALB2 mutation? Third, do they present with low-grade disease, Gleason 6 or low, Gleason 7 or more? Is there a correlation between grade and the presence of a PALB2 mutation? Then we asked as the treatment, what's appropriate? Radical prostatectomy, radiotherapy, brachy or external beam, or surveillance, active surveillance. Then we asked a couple of really out there questions. Does this oncotype test, which I'm not really particularly familiar with in the context of prostate, help determine the use of systematic therapy, curative intent therapy in men with PALB2 mutations? I would highly suggest don't use it unless it's been proven. The new question, which is really theoretical, I certainly think he needs a radical prostatectomy. Would he benefit from olaparib? It's an interesting question. Marc Tischkowitz, based on the Nadine Tongue study and based on the sensitivity of PALB2 in the breast cancer context, would believe that olaparib maybe should be pushed towards giving adjuvant chemotherapy for breast cancer patients with a PALB2 mutation based on the Nadine Tongue study. You could almost extend that question. Could you use olaparib in the adjuvant setting for men with prostate cancer? So I think it raises all these questions, and it's one we're more interested in ever in following. So about 20% of, so you got mutations and you got family history. They don't always overlap. Most people with a prostate cancer family history don't have a mutation. Many with the family history many with the mutation don't have a family history. But there are genes which increase the risk of prostate cancer. We include BRCA2, ATM, CHEK2. What about PALB2? PALB2 encodes a BRCA2 binding protein, acts as a linker between BRCA1 and BRCA2 to form a genome surveillance. Well, we know PALB2 has increased the risk of breast and pancreatic cancer, not so much about prostate. So this study, we did a case control study, and then we followed the people for mortality. We had 5,472 men unselected with prostate cancer. Controls were men and women, 8,016. Basically, we included female controls because the prevalence of the mutations is about the same in unaffected men and women. We genotyped them for two foundry mutations in PALB2. So these are particular mutations, whether they're relevant for all deleterious mutations, whether the risks are the same, is a matter of conjecture, but we only looked for 2 mutations. And the clinical outcomes, we looked at the people with and without cancer, and among the men with cancer, we looked at grade, we looked at age of diagnosis, family history, and prostate cancer specific survival. Basically, there were 16 PALB2 mutations among the 5,000 cases. There was, among the controls, there was 11 among 8,000. So the overall hazard ratio, the overall odds ratio for any PALB2 mutation in prostate cancer wasn't increased, which is kind of surprising. We didn't see an age effect. So there was no real effect on young onset prostate cancer. So in this study, we concluded that the Polish founder mutations don't increase the risk of prostate cancer. If they do, it's certainly not very dramatic. Our best odds ratio was 1.38. But there was no age of diagnosis differential between the carriers and the non-carriers. So now we talk about the prostate cancer cases. The age is typical. The PSA diagnosis was really high, though, 21.2 versus 10.7 in the controls. Having said that, I don't think many of these were screen-detected cancers. They might have been, I don't know. This was clinical diagnosis and screen-detected cancers. Nevertheless, that's a pretty big difference in the PSA, suggesting that these are more aggressive. But if you look at Gleason score, I mean, man, didn't have that many cases, but 9 out of 14 were Gleason 7 or more in the PALB2s versus 18% in the non-carrier prostate cancer. So there's a huge, no difference in age. Then there was a difference in markers of aggressivity. You include both PSA, which of course is a predictor of death, and Gleason grade was a predictor of death. I mean, it went from 18% to 64% high grade. Interesting, though, the case that you presented actually had low grade. So then we went to survival, and it was really too small a number to say anything too definitive, but certainly if we looked at the 16, 18 PALB2 carriers, they all died, as far as I can tell. And the crude hazard ratio was 2.7, strongly predictive. So what does this tell us? This tells us PALB2 doesn't seem to predispose to prostate cancer, but once you get it, it seems to hit in and raises your aggressivity, and you end up with high-grade prostate cancer. You end up with mortality. Could be it could be, and I didn't subdivide this by Gleason because we didn't have that many patients. My guess is these guys underwent grade transition from grade 6 to grade 7, where they grade accelerated before they died. My guess is, I don't know. I mean, the numbers are relatively small to be conclusive, but certainly based on this data, I would suggest we assume that PALB2 prostate cancer are aggressive. And to give the men the benefit of the doubt, I wouldn't treat them with active surveillance. I do the prostatectomy. Does prostatectomy prevent death in high-risk prostate cancers? I haven't shown that, but I give them the benefit of the doubt. Would I add olaparib to the regimen? I mean, if I was sure that everybody was going to die within 140 months, I would be tempted. This is one observational study. It's Polish patients. They weren't screen detected. I assume 2 patients were screen detected, and they probably had high-grade prostate cancer. But I mean, we only had 5 people with Gleason 6 or lower prostate cancer. They all died. And well, I'm not sure they all died, but there were no people that were long-term survivors. So something to continue. These are not easy studies to do. We'd like to be able to expand these and look at other genes. So I guess the questions I want to raise is, it's an interesting kind of gene. It's the only one I know so far that seems to not increase the risk of cancer, but increase the mortality. Now, if we look at that paper by Pritchard, you see if you study men with metastatic prostate cancer and look for the prevalence of mutations, the prevalence of mutations from all these genes, ATM, CHEK2, BRCA1, BRCA2, and PALB2, is higher in men with metastatic prostate cancer than men with localized cancer, suggesting there is an impact of the germline mutation on survival. The frequency of mutations is higher in metastatic disease than in non-metastatic disease for all these genes. The difference between PALB2 is PALB2 is the only one where the frequency of mutations in men with non-metastatic disease is not higher than in men with no prostate cancer. If you look at, I don't know for sure about ATM, but certainly BRCA2, BRCA1, and CHEK2 predisposed to low-grade and high-grade prostate cancer. PALB2 seems to be unique in that it only predisposes to high-grade prostate cancer, and it's the only gene I know of at this point in my studies that predisposes to mortality but doesn't predispose to risk. I think 2 has got probably the most interesting case I've seen that's relevant to this discussion. And I think it's really good that she brings it up. I don't know if any of his family members are at this case conference because I don't want to be, it's not my patient and I don't want to be second guessing the treatment choices made by the treatment at Vanderbilt, but I do think it raises a lot of questions. I know, being a non-oncologist, it's pretty hard to recommend drugs like olaparib off-label for drugs that's never been shown. But these are some of the questions. Last question I want to raise, okay, who to test? This guy had a family history of prostate cancer. I think, you know, we should, if you look at all these genes, if you add them up in localized prostate cancer, probably 5 to 10% of them will have a gene mutation if you include I57-1T. And I'd test all prostate cancer patients. I think it's time we did it and move on and just got the data. I mean, testing people with metastatic disease sounds like a good idea, but I mean, unless you're going to give them some intervention, and there's nothing wrong with evaluating PARP inhibitors in metastatic disease and even maybe in the immune checkpoint inhibitors. But if we're going to get where we want to be, we're going to have to find cases like TUAs, which are, you know, TUA is a perfect example. This is a low-grade cancer. This guy looks to all intents like he has a low-grade, low-risk cancer with the exception that he has a PALB2 mutation. If he didn't have the mutation, I would offer active surveillance. He has the mutation. I think we have to be aggressive and we have to give him a radical prostatectomy and even think about chemotherapy. Therefore, the way to get at this is to test everybody with prostate cancers. Otherwise, these guys are going to slip through the cracks. These are my opinions, and they're probably endorsed by relatively few people. And I'm not a urologist, or I'm not a medical oncologist, I'm not a surgeon. I'm not sure I'm a geneticist, but spent a lot of time looking at numbers and graphs and hope can be helpful. There's no increased risk of prostate cancer associated with the high-grade prostate cancers and poor outcome.
So go to the
directions.
last. Sorry,
We need
Steve.
to evaluate aggressive therapies for PALB2. Yeah, we need to evaluate them. Is active surveillance appropriate for PALB2 carriers? Is there a role for early androgen deprivation, PARP inhibitors, or chemotherapy in localized disease? What's the role of increased screening among men with PALB2 carriers? Should we test everybody? I think we do need a, you know, prospective studies on outcomes for these genes. I have Dr. Roderick Clark with me, who's my fellow. He's a urologist who's been very helpful. Amy Finch, you may know, is now working with us in prostate cancer. Czarek Zabulski, my main prostate cancer colleague in Poland, who's been really helpful. And all the Polish Hereditary Prostate Cancer Consortium, who's helped us collect all these thousands of cases.
Okay, thank you, Stephen. So going back to my case, which Stephen really already outlined very well. So some of the pertinent questions that I came to both Stephen and Mark about, you know, how do we take family history of aggressive prostate cancer into account to potentially guide treatment? So whether it be active surveillance versus radiation therapy versus surgery. And again, I know Stephen has voiced some opinions. I'd like to hear Mark's opinions as well. And then, you know, the urology team, again, I think we're all struggling with what to do next because, again, Oncotype DX, I agree. It's not usually the context in which we use Oncotype DX, but I think it just gives us more information. How we will move forward and act upon it is to be determined. The repeat biopsy, again, I think will be helpful. That's already scheduled at the end of this month. Now, would cancer risk be informed by family history of prostate cancer? In this case, he's got two brothers. I personally like the other brother who had prostate cancer with a prostatectomy also tested. So I've tried to encourage that. And then what cancer risk management would be advised in unaffected PALB2 positive men in the family? So with that, I wanted to bring in the panelists to kind of weigh in. And, you know, I'd love to hear Mark's thoughts on this in particular, and then open it up to Stephen and everyone else.
Thank you, Tia, and thanks, Stephen. That was a very interesting talk. And I mean, I guess one of the points that I'd like to come back to relating to the family is actually, you know, this concept of PALB2 being a gene that doesn't cause a risk, but then predisposes to, is a poor prognosis marker. And how you said that is, you haven't come across a gene like that before. So it's a bit of a paradigm shift almost in our way of thinking. And when we start having those sorts of paradigm shifts, we begin to wonder whether this is really correct, because it's so far out of our, you know, standard line of thinking. So the question is, you know, how confident are we about these observations? And is there any correlation with, I mean, the nearest thing that I can think of is that this is a bit like BRCA2, because there is an enrichment for high-grade prostate cancer in BRCA2 carriers. Maybe are we seeing the same sort of pattern in PALB2 as in BRCA2, but it's an issue of numbers. We don't have enough numbers at the moment for PALB2. I mean, that's a question for Stephen, really.
Yeah, I mean, you're right. If we had more data, I'd be happier with the conclusions. You're absolutely right. I mean, either the, you know, so the questions, the good questions, how do you correlate survival in a gene versus risk? So that, you know, we've thought about this, and if you want to know if a gene is a bad risk gene in terms of survival, there's several ways you can do it. Compare the frequency of mutations in metastatic disease compared to localized disease. One, look at the grade distribution in men, the high grade versus low. Two. Three, look at the time to recurrence. You could look at the time to biochemical recurrence. You could look at the time to metastatic disease. Three, you could look at the time to death. So, you know, when we do that, I don't know, I can't remember in that Pritchard paper if we compared the frequencies. So you want to look at the frequencies of mutations in the general public and the public with localized disease and metastatic disease. Certainly in the Pritchard papers, for almost every gene, the frequency of mutations was higher in the metastatic than in the localized, suggesting that it affects survival. Yeah, I don't know what the numbers are. I mean, if there are other numbers, good. Could this be due to confounding? No, don't think so. These two guys didn't get screened. This is Poland. We just took 5,000 unselected patients. They didn't know they had a mutation. That's for damn sure. None of these people knew they had a mutation, and we did it retrospectively. We did it going back, I think, 15 years. Did they get differential treatment? No. Did they have family histories? Now, it's weird, you know, because two has got a family with 3 cases, and we say that doesn't increase the risk. But in your 3 cases, how many were known mutation carriers to? All 3?
No, so my patient initially presented before he even had the prostate cancer diagnosis, right? So he's PALB2 positive with quote unquote low risk right now, Gleason 6. His brother died of prostate cancer, but he'd started with low risk, and there was progression, right? So he had aggressive prostate cancer. He died of metastatic prostate cancer.
The stage progression is very interesting. It's something, yeah, we got to ask. So what? You got Gleason 6. I think, and we're having discussion here in my own research, is everybody with low-grade Gleason that dies of prostate cancer experience stage migration, or can low-grade be an indolent disease. Some do, some don't. There's certainly not everybody gets re-biopsied. And there are plenty of people who have low-grade prostate cancer that die of prostate cancer. But this stage migration looks like a bad actor.
Yeah, and that's why, I mean, this patient was very close to his brother. They were only a year apart. So my patient is very apprehensive and is being as proactive as he possibly can.
I don't want to interrupt, but I mean, when you had the discussion, this is really cool. So the guy goes to see his doctor. I suppose you're not at the discussion, but there's a discussion between the surgeon, the urologist, presumably, right? And the
Yes.
patient about the next steps, and the options are on the table. Like, that's a real hard discussion. I mean, I give the guy a lot of credit to be entering that discussion from a urologist point of view. How did the patient react? Did the patient say, listen, man, I'll give you the rod, I'll take the prostatectomy, or did he say, I want to avoid it, or I prefer, I mean, is it up, how much of the patient makes the decision, how much is it the doctor?
I think the patient has a lot to say here. And I actually read through the medical notes, and I've talked to the urologist. He really had an extensive discussion about this. And the PALB2 certainly has guided it. And that was before your paper was published. So I've brought him up to speed with this new paper as well. So this is, again, they already had the Oncotype DX planned. They already had the prostate cancer biopsy planned, but they're definitely using that information to guide what ends up happening next. But the patient is open to all treatment options. He just wants to make the best decision for himself.
Of course, we all want to make the best decision for himself. And that, to me, is the one that avoids the progression and recurrence. I mean, you know, there's only sort of one outcome here. If we knew it wasn't going to progress, we knew this, we would go with the, but he's relatively young. I think, you know, I mean, not putting more work on your plate, I think this case is so interesting. It covers all the bases. If I were you, I'd write it up and try and, you know, I think you, like, we present some numbers, Mark says maybe they're bogus. Yeah, sure, they could be. And then you cover all the bases here. I'd write this up.
I do have a question just in terms of considering the management, and we have Carrie Schaefer who's on the call. And my thought is, what is the overriding issue in terms of treatment? Is it that it was low risk and now is a higher risk? Is it the PALB2? Is it the combination of the two? And I think those are the things that, you know, probably need to be balanced a little bit more. And your, you know, Stephen, your data is really helpful. But I think I put in the chat, this is so reminiscent of, we don't have enough data to try to understand what to do with people's risks and how do we navigate that. So we're not over treating, under treating, trying to get things just right. It's very interesting that we're kind of here with another gene in the same sort of set. I wonder if Carrie has some thoughts about this.
Yeah, I'm Carrie Schaefer. I'm a medical oncologist with a focus on prostate genetics. And first off, I just want to say fantastic that this conference is being held. And it's really wonderful to have some literature out there about this particular gene. And I've not met this patient myself, but I do think I'm similar to Dr. Narod. I would lean, because he's young and given his family history, towards treatment rather than active surveillance, if he is even thinking about it, just based on his brother's history. I think it's reasonable to get that, you know, oncotype, but if that is showing lower risk disease by oncotype, I don't know that I would put a ton of weight in it. So I think it's more data, but not necessarily something that would drive the ultimate decision. And, you know, and it's possible that his biopsy didn't get the most high grade cancer and that he already does have higher grade. But I think, being how young he is, I would lean towards treatment with surgery, including a node involvement. You know, with BRCA, they have data about more node involvement in that setting. And so it would be nice just to know if there already has been some migration of the cancer outside of the prostate. But yeah, those are my main thoughts. And I'm so glad that there's more literature about this particular gene now.
Yeah, no, thank you, Carrie. And so that's why I think it's great that they're going forward with a repeat biopsy. But you're right. The issue is, say you find the same thing, say Oncotype DX, like a high risk score or finding a higher Gleason will help. But if you don't find it, you're still kind of stuck with what you have right this second. And is that enough to go forward? And, you know, I know that the urologist had a very comprehensive discussion, and he's certainly given the patient a very balanced discussion. So it's a tough case.
It is, you know, a large proportion of people that do active surveillance change over time to undergoing surgery. And so for him, if this is his window of opportunity for curative surgery, maybe he'll maintain better urinary function or sexual function for a few years. But I feel like that risk benefit, given his brother's history, is maybe not worth it. And it might be easier for me to say that as I'm not doing the surgery, but then,
you know, the other thing I want is for the other brother to get tested to see if the aggressive prostate cancers are tracking in the family with PALB2, because I think that would give us at least a little bit more information. I don't know that it's going to change anyone's mind, but again, if it is tracking with PALB2, because again, I don't have the medical records of the brother who's not tested, but he had a prostatectomy, which implies to me it was probably aggressive prostate cancer, right? So, or a higher Gleason stage. So again, we'll see what happens with that, but all great
it'd be
points.
very interesting to do somatic testing on any of these prostate specimens available to see if perhaps they're coming up with aggressive somatic mutations that are driving that more aggressive phenotype in your.
You know, that's a great idea. So when they do the biopsy, I wonder if they would think about doing, you know, Tempest testing or tumor sequencing. Is that what you're thinking?
Yeah,
That might be something.
I bet we could get Tempest to do it too.
I was thinking that too, and you can get the HRD assay.
Yes.
Yeah, those are great ideas. You know, this is a great discussion, but I want to leave time for the next case, and then we're going to come back as a panel. So we have the team from France presenting a really equally interesting case, I think. So I'll let them take it away.
Good afternoon, everyone. First of all, thank you so much to let me the opportunity to present this case. It's about Mr. Eyre, born in 1978. He's 42 years old, and also he has no medical history related until a few months ago. In September 2020, he suffered from bladder irritation, such as pollakiuria, otherwise a kind of small urinary volume without any infections element. His rate of PSA was 5.48 nanogram per millimeter. And at rectal touch, he has an induration of the left lobe of the prostate gland, and as a consequence, a suspicious local invasion. So, as you can see on the left side of the slide, an RMIT1 with gadolinium injection, a moderate hypertrophy of the prostate, an altered left lobe of the prostate. In fact, it appears as heterogeneous contrast. It is also confirmed on the other second slide on the right. Afterwards, a biopsy was realized and confirmed the diagnosis of prostate adenocarcinoma, lesion score 7, 4+3, also considered as intermediate to high risk, with invasion of the left seminal vesicle, the apex, and the right peripheral of the gland. To improve the evaluation of metastasis, the bone scans was normal. As a therapeutic attitude, a radical prostatectomy was realized in association with a regional lymph node dissection. The histological analysis after surgery objectified an adenocarcinoma, PT3B N0MX, ESUP3, lesion score 7, or N+/3N, R1. The multidisciplinary consulting meeting decided a careful monitoring. What the family story is concerned is mother died at 62 years of age of a bladder cancer, and she also had a sister and two brothers They all died of unspecified cancers. His maternal grandfather died of lung cancer. Tobacco consumption is unknown. And now our genetic consultation department was solicited to perform a genetic analysis in the context of early prostate cancer by the oncologist and urologist. After the genetic consultation, a genetic analysis with 13 genes involved in cancer hereditary predisposition was performed. Molecular analysis identified a germline heterozygous loss of function variant of PALB2 C.751 C2T as described on the screenshot of Alamus software. 3 occurrences in ClinVar were found. Thank you for your attention.
Thank you so much. So we'll go back to the panelist view. Would love to hear Stephen's thoughts and Mark's thoughts as well as the experts.
This is I mean, I'm not sure really. I think the patient had appropriate management. Do we think of any other management? Maybe what could be the options added on would be a kind of an adjuvant radiotherapy or an early intervention with an anti-androgenic therapy. I'm not a urologist, so I don't want to say more than that. I mean, one of the questions is, he got what I would consider pretty good curative therapy. Do we wait? The traditional thing would be wait till biochemical recurrence to introduce an anti-androgenic therapy. Usually you get prostatectomy or radiotherapy. We think this looks like an aggressive disease. Is there any role for adjuvant radiotherapy or anti-hormonal therapy other than in the standard progression?
What about PARP, Stephen?
Well, like I said, I think it's a good idea, but I mean, I like it, but I mean, not being a medical oncologist, you have a hard time running around giving out expensive chemotherapies. Like, certainly there's no question that if you had a bunch of patients like this and had an opportunity to do a randomized trial with adjuvant olaparib at now versus placebo, that would be a wonderful source of information. I mean, everybody would endorse such a study, I think for 5 genes, right? I don't know what's going on. Like, is there a study now for adjuvant or PARP inhibitor therapy in the prostate cancer of these high risk? I mean, sure, yeah.
There is a trial going on right now. I'm not sure if PALB2 is in the list.
Is it in the list?
Yeah, I'm not sure. I'm looking it up right now.
But you know, if there's a trial going on, it's kind of hard to say to just don't wait for the trial and give them the drug.
It's hard.
Mark,
It's hard
what are
without the evidence. Well, I mean, I agree. I mean, I think we all feel that olaparib, you know, would be an attractive choice here, but it's hard without. It's very indirect. I mean, it's already indirect in the breast cancer setting because we just have the Olympia study, and here we're making another step. So, and it comes back to what I said before about, you know, it's not a cheap drug. It's well tolerated. I mean, you know, it seems less harmful than standard chemotherapies, but it's expensive. So how can you justify? You know, so the justification will be difficult, and depending on which healthcare system you work in.
That, Mark. I mean, the first PARP inhibitor trial in breast cancer, or was it in BRCA, and I guess was metastatic ovary, and then metastatic breast, and blah blah blah. And 10 years later, we went into adjuvant olaparib, right? And lo and behold, it worked.
Mm-hmm.
There was a question about whether olaparib is covered in France.
Well, I'm just saying, you can wait 10 years, you know. The patient, it's great for us to sit here and get older and watch them trickle through to eventually in 10 years from now, we're going to do an olaparib trial on people with PALB2 mutations. But I get, it just takes a hell of a long time.
Yeah, I get the impression the drug company is missing a bit of a trick here, and the oncologists are as well, because they you know, people know about BRCA1 and BRCA2, but they don't seem to know about PALB2. And it is going to be harder because it's rarer. But even, you know, the drug company could be pushing this a bit harder as well, expanding it, you know, beyond BRCA1 and BRCA2, I think.
You know, what I
Anyway.
find fascinating, I know we're at time, what I find fascinating is the Polish data for prostate cancer mirrors what was seen for breast cancer in that paper that you were involved with a few years back, right, Stephen? So, you know, I'm really excited to see the study results from Kelly's paper, and then Mark's also leading efforts in the UK. So again, I think that's much, much needed information for us to guide, well, how do we treat these patients when we see them? How do we advise them? And again, even if the risks are lower for breast cancer, if the risk of death is higher, that could guide whether they choose mastectomy or not.
Yeah, you're right, you're right. I mean, whether prostatectomy and surgical prevention is an option, people discuss it. But yeah, I forgot to say that, and I'm really glad you brought that up. The prostate cancer data mirrors exactly the breast cancer data. We compared PALB2 breast cancer patients to those with no mutation with BRCA1 mutations, prospectively, and the PALB2 women did way worse. Probably something going on, right? I thank you for raising that. If I don't.
Okay, well, you know, I got to thank our guest experts. I think this has been a really, really informative and exciting case conference. I'm going to let Brenda take over to go over just a last few housekeeping slides.
Thank you. Thanks, everyone. We have some upcoming themes for the upcoming case conferences. So we have actually Carrie Schaefer that was on the call. She'll be presenting on inherited prostate cancer 2 months from now. And then we have rhabdomyosarcoma and neuroblastoma by Doug Stewart, SMARCATE4, and inherited pediatric cancer. So don't miss those conferences. And then just another, we also want to mention another opportunity by the UK Cancer Genetics Group, which is a monthly journal roundup. Participants receive a monthly summary of genetics publications, and then also have an option to contribute to the journal roundup by producing and sharing their own journal summaries. So if you're interested, you can send the journal summary with the title of the journal to Izzy Turbin, and I'll put her contact information. But if you in the chat, but if you want, you can reach out to me and I can share that with you. If there is a journal that you're interested in, or you know, 1 month you have more time, or a journal comes out and you wanna share and you wanna summarize it with the group to contribute to the education opportunity. Reach out to her before you do so, just to make sure that it has not been covered before. The 4 main categories are bigger picture, translational science, in the clinic, and counseling and ethics. So it sounds like it covers all areas of genetics. So thanks everyone for attending. I will put her information in the chat, but again, reach out to me if you have any questions. And thank you all for attending.
Thanks, Brenda.
Thank you.
Bye,
That's very good.
everyone.